Good afternoon. My name is Dr. David Andorski. I'm a medical oncologist with the Rocky Mountain Cancer Center in Colorado, as well as the U.S. Oncology Research Network. And I'm happy today to talk to you a bit about the findings from my abstract from a selection of patients from the MAGNIFY trial, which is Revlimid and Rituximab, followed by maintenance therapy in relapsed and refractory non-Hodgkin's lymphoma. We'll specifically be looking at subsets of patients with follicular lymphoma who were either double refractory to earlier lines of therapy or early relapse after first diagnosis. So in general, follicular lymphoma these days has a good prognosis, but some patients who can be identified who have adverse prognostic factors. In particular, patients who relapse within 2 years of their initial diagnosis have adverse outcomes, as well as patients who are refractory to both rituximab and chemotherapy. Lenalidomide and rituximab is active and well tolerated in first-line and relapsed and refractory follicular lymphoma. Both of these agents both have direct effect on the tumor as well as immunomodulatory effects and work synergistically to improve the efficacy of the immune response to the lymphoma. This is the design of the MAGNIFY trial overall. It's enrolling patients with relapsed and refractory non-Hodgkin's lymphomas, either follicular lymphoma, marginal zone lymphoma, or mantle cell lymphoma. All patients receive induction therapy with lenalidomide and rituximab, and then after 12 cycles are randomized to either the R-squared combination as maintenance therapy or rituximab alone. The primary endpoint for the study is progression-free survival. Here's a snapshot of the patients we'll be discussing today. Of the 234 patients accrued to date on the study, 160 had follicular lymphoma. 52 of them were early relapsers, meaning that they had relapse or progression within 2 years of diagnosis, and 50 were double refractory, meaning that they were refractory to an alkylating agent and rituximab. You can see the overall response rate for the follicular lymphoma cohort as a whole was 67%. The double refractory patients had an overall response rate of 45% with 21% complete responses, and the early relapsers also an overall response rate of 47% with a complete response rate of 21% as well. Here's a waterfall plot showing the responses among double refractory early relapsers and patients who are both double refractory and early relapsers. As you can see, most patients had some degree of tumor response. The patients who are rituximab refractory are marked with an asterisk, and those patients too also tended to have favorable responses, including fairly deep ones. This was also true of patients who were both double refractory and early relapsers, denoted by the purple bars. The 1-year progression-free survival for the overall follicular lymphoma cohort was 70%. Among the double relapse patients, it was 65%, and among the early relapsers, 49%. The median duration of overall response was not yet reached in either cohort of patients, though the follow-up for this study is relatively early, with 10.2 months of median follow-up on study to date. In conclusion, the R-squared induction therapy followed by maintenance showed favorable activity and a tolerable safety profile in follicular lymphoma patients who were double refractory or had early relapse less than 2 years after the initial diagnosis. The most common grade 3 or 4 adverse events were hematologic, including neutropenia, leukopenia, thrombocytopenia, and lymphopenia, and enrollment in MAGNIFY is ongoing. Thank you for your time and attention.